Hi everyone. So in this video, we are going to discuss about the CVS disorders. That is most commonly in this video, I will be discussing about the congestive heart failure, acute rheumatic fever, and the infective endocarditis. So uh, first is about the congestive heart failure. That is in majority of the university pediatric examination, there will be questions regarding the congestive heart failure, like the what are the causes and clinical manifestation of congestive cardiac failure in infancy as well as childhood. And another question is like what are the management of the congestive cardiac failure in the case of children. So these are usually asked questions regarding the congestive heart failure. So moving on to the definition of the congestive heart failure. So if a essay question is or any short answer is based on the congestive heart failure, we have to first write about the definition of the congestive heart failure. That is the definition. Congestive heart failure, as the name indicates, it is the failure of the heart function. That is, heart function is to pump the blood at a rate to meet the needs of tissues. That is the function of the heart. So, if there is any failure of the heart to pump the blood at a rate to meet the needs of the tissue, that is called as the congestive heart failure. Then, what are the causes? Depending upon the age, there are different causes for the congestive heart failure. For the first week of life, the reason for the congestive heart failure in the first week of life is birth asphyxia, myocarditis, and hypocalcemia, and also congenital heart diseases like aortic stenosis or pulmonary stenosis and hypoplastic left heart syndrome. So these are the causes for the congestive heart failure in the case of the first week of life. Then at 1 to 2 months of life, the most common causes for the congestive heart failure is the large BSD and the patent ductus arteriosus. Then in the 2 to 6 months of age, the causes for the congestive heart failure are the ventricular septal defect, patent ductus arteriosus, and coarctation of aorta. But in the older children, the causes are like rheumatic heart disease and acute rheumatic fever, and then cardiomyopathy, then congestive heart disease complicated by the infection, anemia, and infective endocarditis. So these are the causes in the different age groups of the children. Then about what are the clinical features of the congestive heart failure. So a patient with the congestive heart failure, because of the above causes, results present with the tachycardia, tachypnea, hepatomegaly, feeding difficulty, and basic palpitations. In the infants, it is usually infants present with the poor feeding, the sweating over the forehead, and tachypnea. So, if a question is in the question, there will be the presence of the symptoms like if poor feeding and sweating over the forehead and tachypnea. That is indicative of the congestive heart failure in the children because of different reasons. In the poor weight gain is because of the feeding problem plus loss of calories due to the increased work of breathing. So these are the clinical features, and the poor weight gain is a consistent hallmark in the young infants also. In the older children, there will be dyspnea on the exertion. That is example, climbing stairs, there will be dyspnea, and orthopnea, that is breathlessness, a lying down position, and edema, that is pedal edema, the raised JVP due to the right heart failure, basic palpitations, liver enlargement, and gallop rhythm will be there. So these are the clinical manifestations in the older children. But in infancy, there will be poor feeding and sweating over the forehead and tachypnea. These should be kept in mind. That is sweating of the forehead and poor feeding. That is an indicative of the congestive heart failure. Most of the questions, the question is asked based on these features. That is poor feeding and sweating of the forehead in the case of infants, which is indicative of the congestive heart failure. So these are all about the clinical features of the congestive heart failure. Then what are all the investigation we have to do when a case is present with the congestive heart failure? That is, we have to look for the ECG, that is, which may show the underlying condition. Then we have to look for we have to do a 2D echo, that is diagnostic of underlying condition. That is, if there is any valvular heart disease or if there is any decrease in the ejection fraction, we have to diagnosed by this 2D echo. Then we have to do a X-ray test, that is cardiomegaly. In the X-ray test, we have to find out the cardiomegaly to rule out other respiratory conditions as differential diagnosis. Then routine investigations to assess the comorbidities. For example, hemoglobin, complete blood count, and CRP should be evaluated, and also monitor the electrolytes also. So these are the basic investigation when we are going to do in the case of the congestive heart failure. That is ECG, chest X-ray, and 2D echo for the underlying condition. Routine investigations like CBC, HB, and CRP, and also monitor the electrolytes. Then about the treatment. It is also asked as a short answer, the short note, that is, what are the treatment steps in the treatment of the congestive heart failure? That is also asked as a short note in the university examination. So, first of all, we have to correct the underlying cause. That is congestive heart failure is because of some underlying cause in the children's and infancy. So we have to correct the underlying cause like hypocalcemia, tachyarrhythmia. We have to treat these symptoms, or we have to treat these conditions. And also we have to give supportive measures, that is reduced physical activity which may be difficult in the children. Another supportive measure is to incline the child at 30 degree to pull the edema fluid in the dependent parts and decrease the work of breathing. And we have to treat the any high output conditions like fever and anemia. And mechanical ventilation is administered if it is required, and humidified oxygen as a oxygen administration, and head and elevation. These are the supportive measures for the treatment of the congestive heart failure. Then, then we have the drug management for the congestive heart failure. That is, this is the factors which determines the ventricular function. The stroke volume is affected by the preload and afterload. So in the congestive heart failure, we have to decrease the stroke volume by the either decreasing preload or by the decreasing afterload, and also by increase the and decrease the cardiac failure by the increased myocardial contractility. So the drugs are also used for such purposes, that is to for the reload reduction, afterload reduction, and increased myocardial contractility. So for the preload reduction, we are using the diuretics. That is the mainstay of the treatment. Action starts in the 20 minutes after administration of diuretics. And the mechanism of action of diuretics are which reduces the blood volume and decreases the venous return and ventricular filling. And the side effects of these diuretics are it causes volume depletion, hypokalemia, and hyponatremia. And commonly used diuretics is the furosemide 0.5 to 1 milligram per kilogram per day. So that is all about the diuretics. That is reduces the preload, and thereby it reduces the stroke volume, and which causes the decreased workload on the heart. Then we have the another drug that is used for the afterload reduction, that is ACE inhibitors, that is angiotensin converting and enzyme inhibitors. The commonly used is the enalapril 0.3 to 1 milligram per kilogram daily. Then it is safety and efficacy proven in the children, may improve survival besides giving symptom relief. And the contraindications are the renal dysfunction and hypovolemia, and the fixed obstructive lesions, that is aortic stenosis, mitral stenosis. We are used ACE inhibitors. And the cough is a troublesome side effect of the ACE inhibitors. So if there is a severe cough, we are using ARBs, that is angiotensin receptor blockers, instead of the ACE inhibitors. Then another drug which causes the increased myocardial contractility, and thereby the increases the function of the heart by the increased myocardial contractility using inotropes and digoxin. Digoxin is indicated in the congestive heart failure with or without sinus rhythm, role in the volume overload situation with the normal cardiac function and controversial. And the recent trend is to limit the use of digoxin due to the lack of the major survival benefits. So increased myocardial contractility by the inotropes and digoxin. So these are the drugs for the congestive heart failure. That is to reduce the preload by the diuretics, and to reduce the afterload by the ACE inhibitors or the ARBs, and to increase the myocardial contractility by the digoxin and inotropes. This is the management of the acute CCF. That is, if there is a sudden onset CCF is there, the mechanical ventilation is of greatest benefit among all the measures to reduce the work of breathing. Then inotropes like dopamine, dobutamine, adrenaline, noradrenaline, and levosimendan in acute decompensated CCF with the shock have short-term benefit in the improving symptoms. And dobutamine has the advantage that it does not require the central line for the administration. And the inodilators like milrinone are also used in the case of the acute congestive heart failure. So these are all about the congestive cardiac failure. So then another short note or another essay discussion is on the infective endocarditis. Um, the usual the question asked in regarding this infective endocarditis are the describe the modified Duke's criteria for the diagnosis of infective endocarditis and discuss its management of the infective endocarditis. These are the usual questions which are asked in our university exam. So first is about the definition. The definition of the infective endocarditis is endovascular microbial infection of the endocardium. That is infective endocarditis, which means there will be an infection of the endocardium. That's the name indicates there will be an indication infection of the endocardium. So there will be an endovascular microbial infection of the endocardium, predominantly which occurs in diseased heart, but can rarely occurs in the normal heart as a part of the generalized septicemia. So usually it occurs in the case of a diseased heart, but can also occur rarely as in the normal heart as a part of the generalized septicemia. And this infective endocarditis, which may worsen the prognosis of an otherwise benign cardiac condition. So it is an endovascular microbial infection of the endocardium, as the name indicates. So that is the definition of the infective endocarditis. And the pathology, the two factors which plays an important role in the pathogenesis of the infective endocarditis. That is, first one is damaged epithelium, and second one is the bacteremia, even if transient. First, that is, if there is a damaged valve or normal valve with the cardiac condition with a steep pressure gradient, the jet of high pressure blood spurting, example through the VSD, hits endocardium, and that causes the endocardial damage. That is, if there is any damaged valve, there will be jet of the high blood pressure spurting that causes the endocardial damage. And in that endocardial damage, there will be colonization from the incidental infection, example skin ear. That is, if there is any incidental infection in the case of skin or ear, the infections colonize to this endocardial damaged area, and there will be a formation of the bacterial nidus is there, and this bacterial nidus, because of this bacterial nidus, there will be inflammatory response and platelet deposition and fibrin deposition will be there, and that will result in the formation of vegetation. And then again, this cycle continues, and that results in the major symptoms and signs of the infective endocarditis. So, first there will be damaged valve will be there because of this high jet pressure of the blood volume. There will be damage of the there is endocardial damage will be there, and then that result, if there is an infection anywhere other than the heart, there will be colonization from the into the endocardial damage area, and there will be formation of bacterial nidus, and that results in the inflammatory response of platelet deposition fiber, that results in the formation of vegetation. And from this vegetation, these vegetation will be embolized and results in the thromboembolic events, and also another some signs and symptoms of the infective endocarditis. That is the pathogenesis for the infective endocarditis. Then about the etiology, that is predisposing factors for the infective endocarditis are the congenital heart disease like ventricular septal disease with the AR, and tetralogy of Fallot and patent ductus arteriosus, etc., etc. Then the second is the rheumatic heart disease, that is mitral or the aortic valve disease. Then prosthetic valves or the repaired congenital heart disease, and host factors like IV drug users and immunocompromised host, poor dental hygiene, skin, ear, and bone infections. So these are the predisposing factors: congenital heart disease, rheumatic heart disease, prosthetic valve or the repaired congenital heart disease, host factors like the IV drug users and immunocompromised host, poor dental hygiene, skin, ear, and bone infection. So these are the predisposing factors for the infective endocarditis. Then usually the causative organisms are the most commonly Streptococcus viridans, then Staphylococcus aureus, gram-negative bacilli or the Pseudomonas. And then fungal, like in the pediatric intensive care unit, patients and those with the central nervous system catheter, there will be that the causative organism is fungal. That is Streptococcus viridans, Staphylococcus aureus, gram-negative bacilli or the Pseudomonas, and fungal are the causative organisms for the causation of the infective endocarditis. Then about the clinical features of the infective endocarditis. The clinical features of infective endocarditis, that is, if prolonged fever of greater than 7 days, usually with the cardiac murmur will be that is the most common clinical presentation. That is prolonged fever greater than 7 days, usually with the cardiac murmur. These are the clinical features of the infective endocarditis. Due to the infection, there will be the fever. That is because of the infection with these organisms, there will be fever, weakness, and loss of appetite. And due to the cardiovascular events, that is because of this vegetation formation, there will be the congestive cardiac failure, the changing murmurs, and appearance of the new murmurs. So the changing murmurs and the appearance of the new murmurs, and also CCF, which is an indicative of the infective endocarditis. And also because of the immunological and vascular phenomena, it is not common in the children occurs. It is usually occurs after 3 weeks. Because of this immunological and vascular phenomena, there will be presence of subconjunctival hemorrhage in the eyes. Then cortical emboli, the stroke and abscess will be the splenomegaly, hematuria, then transient petechial rash and loss of pulses. And there will be presence of osseous nodes and nail fold infects and splinter hemorrhages and clubbing in the hand. So by this order, we have to remember the immunological and vascular phenomena in the case of the infective endocarditis, that is subconjunctival hemorrhages, cortical emboli and abscess and stroke, then splenomegaly, that is due to embolization from the vegetation. Then we have splenomegaly, hematuria, transient petechial rash, loss of pulses, then osseous nodes, nail folded infect, splinter hemorrhage and clubbing. So these are the clinical features of the infective endocarditis. Then how will you diagnose a case of infective endocarditis? That is by the modified Duke criteria. That is these have major criteria and a minor criteria. The major criteria which include definitive blood culture for the organism of the infective endocarditism, and the second major criteria is the definitive echo showing the positive for the infective endocarditis or the new regurgitation. So definitive blood culture and definitive echo which showing the positive for the infective endocarditis or the new regurgitation. So that is the major criteria, and the minor criteria are the fever, the predisposing conditions, and the non-definite echo of the blood culture, vascular phenomena, and immunological phenomena. These are the minor criteria. So major criteria is definitive blood culture and definitive echo, and the minor criteria is fever, predisposing factors, a non-definitive echo of the blood culture, vascular phenomena, and immunological phenomena. So to diagnose the infective endocarditis, two major or one major plus three minor or five minor criteria should be satisfied. That is for the diagnosis of the infective endocarditis, two major or one major plus three minor or five minor criteria should be satisfied. Then what are the diagnostic investigation for the diagnosis of the uh, infective endocarditis? First is the blood culture. That is, we have to take three samples taken within 24 hours, pick up a greater than 95% cases. The cytosampling is not significant. And then we have to go for 2D echo, that is to detect the vegetation, especially the culture negative endocarditis. Then the supportive investigations like routine complete blood count. In this, there will be neutrophilic leukocytosis because of the inflammation and due to bacterial nidus formation. Then normocytic normochronic anemia due to the chronic disease, and the platelet count is decreased, and the urine routine microscopy show the hematuria due to the renal embolization of the immune complex glomerulonephritis. So that is all regarding the investigation in the case of the infective endocarditis. Then about the treatment of the infective endocarditis, if there is culture positive infective endocarditis will be it is the choice of the treatment is as per the sensitivity. Empirical treatment we have to be given, that is IV penicillin or the vancomycin plus gentamicin for the 6 weeks. Vancomycin is preferred as organisms are less sensitive to penicillin. So usual empirical is IV penicillin or the vancomycin plus gentamicin for 6 weeks. And the prolonged course of 4 to 6 weeks, even longer in the presence of prosthetic valve treatment is required. Then what are the complications following the infective endocarditis? Embolic events, that is vegetations which embolized and results in the embolic events, that is in the cerebral as well as in the coronary circulation, and also infective endocarditis which results in the congestive heart failure, and also because of this immunological complex deposition, there will be acute glomerulonephritis will be there. So complications are the congestive heart failure and the embolic events, that in the coronary and cerebral circulation, acute glomerulonephritis because of the immunological complex deposition. Then what are the prophylaxis for the infective endocarditis? Indication for the prophylaxis are infective endocarditis prophylaxis recommendation have been revised in 2007 with more restricted use during procedures, as random bacteremia due to daily activities is as likely to cause infective endocarditis as some other procedure. Oral hygiene is explained to all the susceptible patients. The susceptible patients where the infective endocarditis prophylaxis recommended is that if a patient is having prosthetic valves or prosthetic components of valves, after rheumatic valve repair, we have to provide the infective endocarditis prophylaxis throughout the life. Then unrepaired cyanotic heart disease with the shunts and conduits, we have to give the infective endocarditis prophylaxis. In the case of repaired congenital heart disease with the prosthetic valves or conduits, for 6 months after procedure, we have to give the infective endocarditis prophylaxis. Then repaired congestive heart failure congenital heart disease with residual shunts, we have to give the infective endocarditis prophylaxis. And also history of the previous infective endocarditis patients also, we have to give the infective endocarditis prophylaxis. So these are the group of patients we have to give the infective endocarditis prophylaxis. Then the procedures in the susceptible patients where the infective endocarditis prophylaxis is recommended is, in susceptible patients, prophylaxis is recommended prior to the dental procedures involving handling of gingival tissue and periapical tissue with the perforation of oral mucosa. And the prophylaxis is also recommended for the procedures involving respiratory tract mucosa. So the dental procedures and respiratory tract mucosal procedures are also indicative of the infective endocarditis prophylaxis. In the case of gastrointestinal or the genitourinary tract procedures, the prophylaxis for the infective endocarditis is no longer recommended. And the drugs usually used for the prophylaxis are the oral amoxicillin 50 milligram per kilogram 30 to 60 minutes before the procedure. Single dose 30 to 60 minutes before the procedure, we have to give the oral amoxicillin 50 milligram per kilogram. Or if the patient is unable to take orally, we have to give the ampicillin or the ceftriaxone 50 milligram per kilogram intramuscularly or the intravenously 30 to 60 minutes before the procedure as single dose. And if there is an allergy to penicillin, we have to give oral cefalexin or the clindamycin or the azithromycin or the clarithromycin in the doses. And allergy, if there is allergic to penicillin and unable to take orally, we have to give cefazolin or the ceftriaxone, clindamycin 50 milligram per kilogram IV or IM 30 to 60 minutes before the procedure. So that is all regarding the infective endocarditis. The next topic is acute rheumatic fever. So most of the questions asked in a university exam is based on the acute rheumatic fever. Different questions are asked regarding the acute rheumatic fever. An essay, that is an 8-year-old female child is brought to the OPD with the fever, pain and swelling over major joints, which is migratory in nature. Her ESR is 66 millimeters in first hour. She gives history of sore throat 20 days back. What is the probable diagnosis? Discuss the etiopathogenesis, clinical features, and management of the same. So, in this condition, the diagnosis is acute rheumatic fever. That is, an 8-year-old female child is brought to the OPD with fever, pain, and swelling over the major joints. That is also indicative of the acute rheumatic fever, which is migratory in nature. And this condition will satisfy the modified Jones criteria for the rheumatic fever. So, it is a diagnosis is acute rheumatic fever. And also, there will be short essays like discuss the etiopathogenesis, clinical features, lab investigations, and management of the acute rheumatic fever. Then about the modified Jones criteria, clinical features and investigation in the acute rheumatic fever, penicillin prophylaxis in the acute rheumatic fever, diagnostic criteria of the infective endocarditis, rheumatic fever prophylaxis, rheumatic carditis management, erythema nodosum. These are the usually asked questions regarding the acute rheumatic fever. So to define it is an acute rheumatic fever is an acute multi-system delayed and immune-mediated non-suppurative sequelae of the upper respiratory infection caused by the group A beta hemolytic streptococcus. So it is an acute multi-system delayed and immune-mediated non-suppurative, that is only immune-mediated non-suppurative sequelae of the upper respiratory tract infection caused by the group A beta hemolytic streptococcus. The strains associated are the 1, 3, 5, 18, and 24. Though its incidence has declined, but it still continues to remain a major public health problem in India. That is all about the definition. That is an immune-mediated non-suppurative sequelae of the upper respiratory infection caused by the group A beta hemolytic streptococcus. And about the epidemiology, attack rate is 3 by 1,000 school children. And rheumatic fever in the India, why is India is considered as a high risk zone? That here the prevalence of the acute rheumatic fever is greater than 2 per lakh school-aged children, and all aged rheumatic heart disease prevalence of greater than 1 by 1,000 population per year. Why is rheumatic fever is less common now? Because of the improved socioeconomic condition, improved antibiotic usage in the upper respiratory tract infection, impact of secondary prophylaxis, and also general shift in the epidemiology towards non-rheumatogenic strains. So that is all regarding the introductory part. Then about the pathogenesis of the acute rheumatic fever. That is, the agent is the group A beta hemolytic streptococcus authored strains 1, 3, 5, 18, and 24. And If there is any genetic predisposition or susceptible environmental factors like poverty and overcrowding will be there. The susceptible host at the 5 to 50 years of age have um, a molecular mimicry between the group A beta hemolytic streptococci antigens and human connective tissues and myocardial cells and glycoproteins of the heart wall. So there will be a molecular mimicry between the group A beta hemolytic streptococci antigens and human connective tissue and myocardial cells and glycoproteins of the heart walls. So there will be exaggerated T cell immune response will be there that results in the production of the acute rheumatic fever. And because of this acute rheumatic fever, there will be heart wall damage is there, or the entire cardiac wall will be affected. That results in the pancarditis, usually acute mitral regurgitation with the carditis. And the rheumatic heart disease happens in the case of acute rheumatic fever in the case of 40 to 60% of the acute rheumatic fever patient. Then also the acute rheumatic fever have the extra cardiac manifestations like the Sydenham's chorea, then that is purposeful movement, that is unpurposeful movement, then subcutaneous nodules, erythema marginatum and arthritis. These are the extra cardiac manifestations: Sydenham chorea, subcutaneous nodules, erythema marginatum and arthritis. Then what are the clinical features? Usually the extracardiac manifestations, that is, it also have the molecular mimicry towards the connective tissues in the joints and also towards the heart. So involve joints, heart, brain and skin. So rheumatic fever licks the joint but bites the heart and stings the brain. Sequelae associated with the cardiac involvement only. Latent period is 2 to 3 weeks, and about 20 to 30% of patients give history of an episode of sore throat in the past 3 weeks. And the diagnosis of rheumatic fever depends upon a sound framework provided by the Tuckett's John. So, the rheumatic heart disease is diagnosed by the modified John's criteria. That is modified John's criteria, which includes that is major criteria, which include carditis, that is clinical and subclinical carditis. Then having arthritis, that is migratory or the migratory polyarthritis, then have chorea, subcutaneous nodules and erythema marginum. These are the major criteria. Then in the minor criteria, there will be fever that is greater than 35.8 degrees Celsius in the case of the 38.5 degrees, that is greater than 38.5 degrees Celsius in the case of the low risk areas. And the arthralgia, there will be polyarthralgia in the case of the low risk areas, and increased ESR or the CRP, and the prolonged PR interval. So these are all regarding the major criteria, minor criteria. That is, in the low-risk population, the major criteria which include carditis, clinical or the subclinical, arthritis is polyarthritis, and chorea, erythema marginatum, and subcutaneous nodules are the major criteria in the low-risk population. And the minor criteria in the low-risk population is polyarthralgia, fever greater than 38.5 degrees Celsius, ESR is greater than 60 millimeters in the first hour, and the CRP is greater than 3 milligram per deciliter, and there will be prolonged PR interval after accounting for the age variability. That is the modified, that is revised Jones criteria in the 2015. This is the modified Jones criteria, but the revised Jones criteria will be the then in the this is now ഇപ്പം ഞാൻ പറഞ്ഞത് that is for the low risk population, but for the moderate high risk population, the major criteria is like the major criteria which include carditis, that's clinical and subclinical carditis, arthritis, polyarthritis and monoarthritis, chorea, erythema marginatum and subcutaneous nodules. But in the minor criteria, the monoarthralgia is the minor criteria, first criteria. But in the case of low risk population, there will be polyarthralgia. And the minor criteria, the high risk of moderate population, there will be monoarthralgia, fever greater than 38 degrees Celsius. But in the high risk population, but in the low risk population, the minor criteria is fever is greater than 38.5 degrees Celsius. But in the high risk population, it is fever greater than 38 degrees Celsius, and ESR is greater than 30 millimeters in the first hour. CRP is greater than CRP is greater than 3 milligram per deciliter. But in the case of the low risk population, the ESR is greater than 60 millimeters in the first hour. And also there will be prolonged PR interval after accounting for age variability. And for all the population, the initial episode of the acute rheumatic fever is diagnosed by the two major or one major plus 2 minor criteria. And to diagnose the recurrent episode of the acute rheumatic fever, there will be two major or one major plus two minor or three minor criteria. The essential criteria is previous evidence of group A beta hemolytic streptococcal infection. So to diagnose, the essential criteria should be present. That is previous evidence of group A beta hemolytic streptococcal infection. Along with that, for the diagnosis of initial episode of acute rheumatic fever, two major or one major plus two minor criteria should be satisfied. That is modified John revised John modified revised John's criteria should be satisfied. But for the diagnosis of recurrent episodes of acute rheumatic fever, two major, one major or one major plus two minor or three minor criteria should be satisfied along with the essential criteria. So that is all regarding the clinical features or diagnosis of the acute rheumatic fever. So about the major criteria, polyarthritis, large joints which are involved, knee, hip, ankle, elbow, and shoulder which are involved. Hip and spine are not involved. The pain is the fleeting and flitting type. Very severe pain is happens in the case of acute rheumatic fever. The joint becomes inflamed with the painful restriction of movements for the 2 to 3 days, and then subsides and another joint is involved. That is migratory. That is migratory type. The course is completed in the 1 to 2 weeks. Very dramatic response to aspirin will be there. And rarely this polyarthritis is deforming. If deformity remains, it is called Jackout arthritis. Then carditis is the common and CHF is rare. Pancarditis, involvement of the pericardium, myocardium, and endocardium will be the. In the case of endocarditis, there will be Caricombs murmur will be the, that is an early basal systolic diastolic murmur will be present. Then Sydenham's chorea, that is delayed clinical feature, more common in the girls, rapid semi-purpose movements with the extremities and face with emotional ability, associated with the poor handwriting and poor scholastic performance. Then about the subcutaneous nodules, it is usually the site is on the extensor surface of the joints, that joints of like knees and elbows. Time is greater than 4 weeks after the onset of rheumatic fever. It is rarely seen. And the erythema marginatum, it is usually the site is trunk and limbs. Pink macules with the central clearing will be the spreading serpentiniously, and it is rarely seen. Then these are the investigation like CBC, ESR, increased CRP is raised, X-ray chest showing cardiomegaly, ECG showing the prolonged PR interval, and 2D echo show the carditis, that is mitral regurgitation, and evidence of previous streptococcal infection is diagnosed by the assessing the ASO titer, anti-hyaluronidase and anti-DNase B. Then what are the differential diagnosis of these each features? That is for the carditis, differential diagnosis, viral myocarditis and infective endocarditis. In arthritis, juvenile infective juvenile arthritis. Then reactive arthritis, chorea, Wilson disease, and Huntington. So these are the differential diagnosis. And complications of the acute rheumatic fever is the established rheumatic heart disease, that is mitral regurgitation, mitral stenosis, and that is aortic regurgitation. Sorry, aortic regurgitation, and also infective endocarditis, a complication. These are the complication of the acute rheumatic fever. Then about the treatment, the general measures which include bed rest, treatment of the streptococcal infection, treatment of the congestive heart failure, and the control of the group A streptococci. For the bed rest, for the arthritis, there will be 2 weeks of bed rest is needed. For the mild carditis, 4 weeks of bed rest, and moderate to severe carditis, 6 weeks of bed rest is required. And for the treatment of the streptococcal infection, the penicillin 5 to 50 milligram orally twice daily for 10 days is required, and the benzathine penicillin 6 lakh international unit intramuscularly if it is less than 27 kilogram. And the treatment of the congestive heart failure and the control of the group A streptococci by the benzathine penicillin and cephalosporin, which can also be used. Then next measure is the anti-inflammatory treatment. The cornerstone of the management is the steroids and aspirin. For the treatment of the rheumatic arthritis, aspirin 100 milligram per kilogram per day for 2 to 3 weeks is required till the ESR is normal. And also aspirin 75 milligram per kilogram per day for 2 to 3 weeks is required, total for the 4 to 6 weeks. Then for the mild carditis, aspirin 100 milligram per kilogram for 2 to 3 days, and aspirin 75 milligram per kilogram for 4 to 6 weeks is required. For moderate to severe carditis, prednisolone 2 milligram per kilogram per day for 2 to 3 weeks. After 2 weeks, add aspirin 75 milligram per kilogram per day for the 6 to 8 weeks. Taper the steroids over 2 weeks and steroid aspirin overlap at the 2 weeks. Then above for the treatment of the rheumatoid chorea, rheumatic chorea, a late manifest, that is the Sydenham's chorea is a late manifestation, hence so which may be normal. Reassurance as it is usually self-limiting, though phenobarbital and haloperidol which may be used as symptomatic relief for the rheumatic chorea. Then treatment of the long-term complication, for example, surgery for the mitral stenosis, mitral regurgitation due to the established rheumatic heart disease. That is all about the treatment of the rheumatic fever and its complication. Then about the prevention, we have the primary prevention, secondary prevention, tertiary prevention. For the primary prevention, prevent streptococcal sore throat. Example, prevention of the overcrowding. That is, risk factors are prevented by the prevention of the overcrowding, poverty, illiteracy, and the vaccine in the future, which may be an answer. Then primary prevention, early clinical suspicion of streptococcal sore throat and its treatment with the full 10-day appropriate antibiotics. Example, first generation cephalosporin, amoxicillin, etc. This is usually, theoretically it is possible, but practically it is very impossible. Then secondary prevention, in all the patients recovered from the acute rheumatic fever, to prevent the recurrence, we have to give chemoprophylaxis, that is injection, benzathine penicillin 12 lakh international unit intramuscularly every 21 days after negative test dose. In patients allergic to penicillin, oral erythromycin 250 milligram per twice daily is daily, and WHO suggests 6 lakh international unit for the children less than 27 kilogram. In case of non-availability of the penicillin, oral penicillin 5 which may be used, and the duration of prophylaxis is 5 years. The duration of prophylaxis which include um, patient without proven carditis, the prophylaxis for the 5 years after last episode or until 18 years of age, and the patient with the carditis, prophylaxis for the 10 years or until 25 years of age, and established rheumatic heart disease following valve surgery or the balloon valvotomy, we have to give lifelong prophylaxis. That is the duration of the prophylaxis. That for the patient without proven carditis, we have to give the prophylaxis for the 5 years or after last episode or until 80 years, until 21 years or not, whichever is longer. And the patient with the carditis, we have to give the prophylaxis for the 10 years or under 25 years of age, whichever is longer. And also established rheumatic heart disease following valve surgery, balloon valvotomy, we have to give the lifelong prophylaxis for the acute rheumatic fever to prevent the recurrence. So that is all regarding the acute rheumatic fever. Thank you.